Okay, so this video is about the organism Staphylococcus aureus. I'll also give several features of just the staphylococci in general, even, S. epidermidis, but we're mostly going to focus on Staph aureus. The staphylococci in general are one of the three groups of organisms that I really recommend students spending a little bit of extra time on. The staphylococci, as well as the streptococci and the clostridia, are kind of really high yield organisms. They have a wide range of species, but they also produce a wide range of diseases that can be rather severe, but are also fairly commonly seen. They wind up being kind of a high yield group of organisms to keep an eye on. Okay, but let's start with Staphylococcus aureus. So Staphylococcus aureus, those words roughly translate to golden grapes. And it's not because they actually look like golden grapes, although they kind of do in other ways. So Staphylococcus aureus is a gram-positive cocci. So it can look kind of like a bunch of grapes when you look at it microscopically. And that's kind of my feeble attempt at drawing a bunch of grapes. And the golden part actually comes from when you grow them out on blood plate agar, they'll actually take on this like minor golden hue. So together you get golden grapes. But really, the idea of Staphylococcus aureus is that it's a gram-positive cocci that can be grown on blood plate agar. This can somewhat differentiate it from another gram-positive cocci, the streptococci, because the streptococci often grow in like pairs or chains. So while you can't just use this distinction to automatically identify the two, it can sometimes help distinguish between the staph and the strep. So on blood plate agar, Staph aureus is beta hemolytic, so that means it's going to lyse all of the red blood cells. So you're going to be able to see directly through the blood agar plate surrounding the area where that golden colony will have grown. One of the major things that we use to differentiate the staphylococci from the streptococci is catalase. So catalase is literally an enzyme that is produced by the staphylococci, and what it does is it converts hydrogen peroxide that can be present during respiration to basically water and oxygen. So you can see here, this is a catalase test where basically a swab or a loop of the organism that was probably grown out on a blood agar plate has been added to hydrogen peroxide, and you can see all this bubbling, this beer foam response. And that's literally just the breakdown of the hydrogen peroxide into water and oxygen. Whereas the negative catalase test, you don't see any such reaction. So streptococci are always catalase negative, and staphylococci are always catalase positive. As I mentioned, this is kind of a really large group. So there are 49 different species and 27 subspecies, and most of the staphylococci in general are found on us. You can find them on the skin and in our mucous membranes, which is certainly true for Staph aureus. In fact, humans are the main reservoir for Staph aureus. So we are pretty much the main culprit of our own disease state here. So let's talk a little bit about the structure of Staph aureus now. So first off, it's a gram-positive organism, and it's actually an encapsulated gram-positive organism. So anytime we think about a bacterial capsule, you should automatically be thinking that it's anti-phagocytic. So remember, this capsule here is slimy, kind of like a runny egg yolk. So a phagocyte that's, reaching out a pseudopod or a phylopod to try and, grab onto this and eat it up, it's going to slide right out and roll away. just as if you were trying to pick up an egg yolk because it's very slimy. Not all Staphylococci organisms are encapsulated, but Staph aureus is. There are actually 11 different serotypes of Staphylococcus aureus capsules, so we make antibodies to it. And serotypes 1 and 2 are associated with really, really thick capsules, and they almost never cause human disease. But serotypes 5 and 8 are often associated with human disease. So, you know, this slime layer actually helps the bacteria bind to tissues and foreign bodies, things like catheters and grafts and prosthetic valves and joints and shunts. So it can also kind of play a role in adherence and kind of invasion, or not invasion, but adherence to host tissues. Okay, so that's the capsule. Next, we're going to talk about the peptidoglycan layer as well as polysaccharide A or teichoic acid. So teichoic acids are a major component of the cell wall of gram-positive organisms, and they're usually species specific. However, teichoic acid is a pretty poor immunogen, but it does help with adherence. So it helps the organism bind to our host tissues. If an antibody response occurs, it's typically only because the teichoic acid is bound to the peptidoglycan, which is immunogenic. In Staph aureus, the polysaccharide is composed of erythritol teichoic acid, which differentiates it from Staph epidermidis, which has like a glycerol teichoic acid. So let's talk a little bit about this peptidoglycan layer. So the peptidoglycan layer actually is immunogenic and it's fairly inflammatory. But what's more important, especially when we're talking about Staph aureus, is that it is involved in the antibiotic resistance that we see associated with Staph aureus. Most of you, as you're looking into getting into the medical field, have probably heard of MRSA, MRSA. That literally stands for methicillin-resistant Staph aureus, and that has to do with what's going on in the peptidoglycan layer. So remember that there are antibodies within the cell wall of gram-positive organisms that basically construct this peptidoglycan layer. And these are called penicillin binding proteins, and they are the target of the penicillins that we take in order to inhibit bacterial growth, and as well as other beta-lactam antibiotics is what they're called. So an organism that is resistant to these and the related penicillins and cephalosporins is because it's resistant because it's made changes in these penicillin binding proteins. So bacterial resistance to methicillin, as is the case in MRSA, as well as penicillins and cephalosporins, is basically because the organism has acquired a gene known as MEK-A, and MEK-A actually alters the penicillin binding protein PBP2A, and that has a lower affinity for methicillin as well as other drugs like it, and that basically makes you resistant. So then you have MRSA. So while it itself is not necessarily a pathogenic molecule, the fact that it plays such a heavy role in how we treat this disease makes it a important kind of pathogenic characteristic to be aware of. Protein A. Only Staph aureus creates protein A. This is a really important virulence factor. Basically what it does is it inhibits antibody binding or antibody-mediated clearance of Staph aureus. So how does it do that? So what it does is it actually binds the FC portion of antibodies. Okay, so you have, here's an IgG antibody I'm drawing over here. You can see it's kind of prototypical Y shape there. So it binds the FC portion. So why is that a problem? Well, we use that FC portion. Normally, when an antibody binds to a microbe, it should look something like this. So you have the FAB fragments binding the microbe, and this portion over here is the FC, or fragment, constant fragment. And then things like phagocytes will bind to the constant fragment, and then it'll be able to eat the organism and destroy it. But if the organism is binding the Fc portion instead of the FAB fragment or fragment of antigen binding, which is what is up here, then the phagocyte can't see it, it can't bind it, and it can't eat it. So it's actually a pretty genius way. It's still binding up the antibody, but it's making it so that the antibody can't be used to induce any further immune responses or to phagocytose the organism and kill it. So it actually gets rid of that kind of main opsonin. The other thing it has is this thing called clumping factor. This is kind of like a coagulase. A coagulase is an enzyme that converts fibrinogen to fibrin. So this is on the cell surface. It's interesting because Staph aureus also has an internal coagulase that it can secrete, but this one just stays on the cell surface and it can kind of help coagulate and eat its way through the tissue. All right, so Staph aureus secretes a ton of extracellular products, and they can be in the form of enzymes or toxins, doesn't necessarily matter. So we already talked about catalase, that all the staphylococci have catalase and that it converts hydrogen peroxide into oxygen and water, and that the streps do not have catalase. We talked a little bit about coagulase with clumping factor. You can kind of see the test here. So all that is a protein that's synthesized by Staph aureus, and basically it's going to convert prothrombin or prothrombin derivative to convert fibrinogen to a fibrin clot. So you can see the test nice here. You've got a nice fibrin clot there. Here it is not clot. It's not coagulated, so it's a negative coagulase there. But this is positive, and this is what it would look like for Staph aureus. And this is actually useful diagnostically. So coagulase is actually one of the ways you are going to distinguish Staph aureus from something like Staph epidermidis. Because Staph epidermidis is sometimes referred to as coagulase negative staphylococci. So coagulase is kind of a diagnostic test that we can use to identify specifically Staph aureus from the other staph. It also has a hyaluronidase. 90% of the Staph aureus strains that we currently see have a hyaluronidase. All that's going to do is hydrolyze hyaluronic acid. Remember that hyaluronic acid is found in our extracellular matrix, so the extracellular matrix of host tissue. And the reason why that's important is that it actually facilitates the spread of the organism during the early stages of infection. It has a staphylokinase that is phage encoded, so that means it got it from a bacteriophage. Once again, this one's just going to digest fibrin clots. So this one digests clots, this one makes clots. Its production is kind of dependent on the presence of the phage because it is phage encoded. Lipase, all Staph aureus organisms have a lipase. That just means it hydrolyzes lipids. About 30% of the non-Staph aureus staphylococci will also have lipase. So about like 30% of your like Staph epidermidis or I don't know, Staph hemolyticus, they might have it. Nuclease, all the Staph aureus also produce nuclease. Those basically cleave DNA and RNA, so it's a nucleic acid enzyme. Penicillinase, so that kind of makes sense, right? So beta-lactamase is encoded by the presence of a plasmid, so this is only for the strains that actually have the plasmid, or the bacterial chromosome, but it's typically plasmid. And it can be transmitted among staphylococci, and it basically confers resistance to penicillins. That's another way we basically knock out some of those cell wall inhibitors. On the toxin side, we have alpha hemolysin, or alpha toxin. It's a hemolytic and necrotic toxin. It is typically plasmid encoded, but it can also be on the bacterial chromosome. And the toxin basically disrupts the smooth muscles in blood vessels, and it's toxic to a lot of different cells. Red blood cells, white blood cells. It's an equal opportunity lytic agent. Hepatocytes, platelets. Basically, it binds to the cell surface and it causes a rapid efflux of potassium and influx of sodium and calcium, and that just leads to osmotic swelling and cell lysis. It's believed to be an important mediator of the tissue damage that we see in staphylococcal diseases. Beta toxin, that's a sphingomyelinase C. It's actually a heat labile toxin, and it's produced by Staph aureus strains. And it can be toxic to red blood cells, fibroblasts, white blood cells, macrophages, and it's just basically hydrolyzing the membrane phospholipids in susceptible cells. Then you got delta toxin. This one's produced by Staph aureus. It's also produced by S. epidermidis and S. hemolyticus. It's cytolytic. It basically works like a detergent. It works like soap, just destroying the cells that way. Gamma toxin. This is from basically your Staph aureus organisms, and it's involved in pore formation. And then at the bottom here, we have this list of toxins that are in red. These guys are kind of important, if only because we associate them with specific diseases. So there's the exfoliative toxin, or exfoliatin, ET. That's going to lead to scalded skin syndrome, or staphylococcal scalded syndrome, 4 S's. It produces enterotoxins that lead to food poisoning. And then toxic shock syndrome toxin. TSST1 is how it is also known, and we'll talk about that in depth as we talk about toxic shock syndrome. Okay, so Staph aureus basically causes one of 5 distinct diseases, kind of depending on the toxins it has and how it is introduced to the host. So the 5 diseases, you can have kind of like a localized cutaneous infection, which will look like impetigo, furuncle, folliculitis, and carbuncle. You can also get more severe, and if it has that exfoliatin toxin, you can see the staphylococcal scalded skin syndrome. The enterotoxins will lead to food poisoning. And toxic shock syndrome, or is basically the work of TSST1. So let's talk a little bit more in depth about these various toxins. So the exfoliative toxin, or ET, is basically a protease. And the protease is what causes the SSSS. So it's either from a chromosomal type of toxin, which would be ETA, or you can have a plasmid encoded form, which is ETB. It doesn't matter how you get it, because what it does is it cleaves desmoglein 1, which is found in intracellular attachments between cells of the granular layer of the epidermis. And since it's found in that layer of the epidermis, you actually see desquamation of the skin. You're most often associating staphylococcal scalded skin syndrome with young children, whereas gastroenteritis caused by the enterotoxin, well, that's an equal opportunity offender. That one can affect anyone. There are numerous distinct staphylococcal enterotoxins. There's a whole bunch of them labeled enterotoxin A through enterotoxin X. Enterotoxin A is most commonly associated with food poisonings. Enterotoxin C and D are typically found in milk products, and enterotoxin B causes this staphylococcal pseudomembranous enterocolitis. So that's actually the work of enterotoxin B. Just if you're kind of keeping track at home. These are heat stable, and they're actually resistant to hydrolysis by gastric and jejunal enzyme, which makes sense because they cause disease in the gastrointestinal tract. Okay, so then TSST1, this is probably the most devastating of the various toxins. It's estimated that 90% of the Staph aureus strains responsible for menstruation-associated toxic shock syndrome and half of the strains responsible for other forms of toxic shock syndrome produce this enzyme TSST1. And its presence can be lethal, as it pretty much affects a lot of different organs, and it also has superantigen activity. So what do I mean by superantigen activity? So in your cell self-study guide, you learned about a little bit about T cells. So T cells are antigen specific, right? They only respond when their antigen of interest is in place. They also only ever see their antigen in this thing called MHC, which we're going to talk a lot about in immunology. But basically it's presented by specialized cells like macrophages or dendritic cells. They present the antigen, and if the T cell recognizes it, the T cell gets activated. And when it gets activated, it's going to produce some cytokines, namely IL-12, interferon gamma, basically pro-inflammatory cytokines that are going to affect the microenvironment around it. So the difference here, when you have something like TSS-T1 acting like a super agent, instead of having your T cell recognizing an antigen, it's basically the immunologic equivalent of hot wiring a car. So you no longer need the antigen. So here's our MHC molecule, and you can see there's no antigen in it, but instead what exists is this super antigen that's kind of locking the two together, and that super antigen is TSS-T1, and it's basically sending an overwhelming, like a really, 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 really strong activating signal. So instead of getting an appropriate antigen-specific response from one or two T cells that will then proliferate to produce cytokine, you're going to get an overwhelming active response from a whole bunch of T cells because there's no antigen. So it can literally be any T cell instead of a specific targeted event. And that's kind of the work of a super antigen. So when that happens and you get this overwhelming cytokine secretion, you basically get a really strong inflammatory response. You get leakage of endothelial cells and cytotoxic effects at high concentrations. You can penetrate mucosal barriers. And even if the infection remains localized in one site, you'll still see systemic effects. And death in patients with TSS is typically caused by hypovolemic shock leading to multi-organ failure. And then the other thing that can happen with staph infections is a result of bacteremia. So you can get acute endocarditis, pneumonia, osteomyelitis, and something known as septic arthritis. So we're going to go through each of these in a little more depth. Okay, so like the streptococcal infection, Staph aureus can cause impetigo, which is basically superficial or bullous impetigo. You can also get inflammation of the hair follicles, which is folliculitis. When it takes place near the eyes, that's a stye. A furuncle is actually basically just boils. They're an extension of folliculitis, which are large and painful and have raised nodules. Carbuncles involve the deeper subcutaneous tissue when furuncles coalesce, and with those you're going to get systemic symptoms and potentially bacteremia. And then staphylococcal scalded syndrome. This one is also known as Ritter's syndrome. Basically, it's characterized by this abrupt onset of localized perioral erythema, redness, and inflammation around the mouth, and then that spreads over the entire body within about 2 days of the initial onset. If you get slight pressure displacing the skin, that's a positive Nicoskele sign. And you get large bullae or cutaneous blisters forming soon after. And then eventually you'll get desquamation of the epithelium. The blisters contain like a clear fluid, so there's no organisms or leukocytes. And that's basically indicative that this is being caused by a toxin, because if it was being caused by the organism, then you would see the organism itself and the leukocytes that are there to attack it. Everything will be fine again in about 7 to 10 days once antibodies appear and the toxin disappears, and scarring doesn't usually occur because the top layer is just sloughed off. This occurs most often in neonates and young children, and mortality is less than 5%. Okay, staphylococcal food poisoning. This is one of the most common foodborne illnesses, and it's a result of an intoxication, and not like an alcoholic intoxication. It basically is the result of the enterotoxin, and the enterotoxin is preformed. So that means you're going to see symptoms pretty rapidly, like within an hour to 6 hours potentially. The most commonly contaminated foods are processed meats: ham, pork, custard-filled pastries, potato salad, and ice cream. Basically anything you're going to come across at a great barbecue in a backyard somewhere. The symptoms produced are pretty much associated with this toxin, primarily type A enterotoxin, then D and B. And like I said, it's going to be pretty rapid, 4 to 6 hours at most. Basically what happens is the toxins stimulate this intestinal peristalsis. Occasionally it affects the CNS, but pretty rarely. They're considered to have kind of like a super antigen-like activity. Because the disease course is so rapid, you don't typically get more toxin produced by the ingested staphylococci. So even if these dairy products have staph in them, that's not really your big concern. It's the toxin that was already building up as the food was sitting out in the sun all day. So think of it, you're, at a barbecue somewhere. The host made all the food, put the food out at noon when people were eating lunch, and then you spent the rest of the day outside playing, hanging out with friends and family, whatever. And now it's, 4 hours later and you're a little hungry and you come back and you decide to have a little bit more of potato salad. Well, you wouldn't have gotten sick the first time because it was freshly produced, but in the meantime, some kid shortly after lunch came up and, reached in and grabbed some potato salad with their hands, because kids are animals, and they introduced some staphylococci into the potato salad. Now that potato salad has been sitting for 4 hours in the sun, getting nicely cooked, and it's producing this enterotoxin, and now you eat it, and an hour later, severe vomiting, diarrhea, abdominal pain, nausea. All of these are characteristic of staphylococcal food poisoning. And if you look at this kind of interesting graphic here, you can see that there's kind of like a time of year that's associated with staphylococcal food poisoning. And it does seem to tick up in these summer months, July and August, when you expect people to be outside enjoying maybe some of that potato salad that's been sitting in the sun. Some strains of Staph aureus can cause enterocolitis, which is basically a watery diarrhea, abdominal cramps, and fever. It typically occurs in patients who have recently been on some sort of broad spectrum antibiotics that basically are suppressing the normal microflora of the gastrointestinal tract, and that allows the Staph aureus to grow there. Okay, the last and by far the most severe disease associated with Staph aureus is this toxic shock syndrome. It was first reported in actually the 1980s as a complication basically of tampon usage. It was basically described in menstruating women. The reports basically showed that there had been a really dramatic increase in the incidence of toxic shock syndrome in women. And basically it was discovered that these TSST1 strains of S. aureus were able to multiply rapidly in the hyperabsorbent tampons and basically release the toxin. And like I said before, the toxin is a super antigen, so you're going to get, massive proliferation of these pro-inflammatory cytokines, TNF, interferon, IL-1. So basically what happened was they recalled the tampons and the incidence of disease decreased rapidly. And these days we see fewer than 100 cases in the US each year, and they're not necessarily associated with tampon use anymore. They can also be associated with like wound dressing that isn't changed, or any other way that, wounds are not maintained, not kept clean. The clinical manifestations start pretty abruptly. You get fever, hypotension, and then you can get this diffuse macular rash. It's erythematous. It's red, very dark. You can see it on this patient here. And then you get multiple organ system failure: CNS, GI, hematologic, hepatic, musculature, and renal. And it's all involved, as well as the skin. And if this patient had survived, you can see a little bit on her hand and arm here that the skin is beginning to desquamate, basically just slough off. Okay, and lastly, there are a collection of diseases that we see because the organism gets into the blood, so because the patient becomes bacteremic. And that basically just means that wherever the Staph aureus was, now it is spread somewhere else. One of the important ones is pneumonia. We can see it spread to the lungs. Most often, we see it spread to the lungs following some sort of incident. So remember that Staph aureus can be normal flora. So when it's normal flora, it's not going to cause disease. It's only when it moves somewhere that it's not supposed to be that you wind up with disease. So for instance, if you have the flu, when you have the flu, you can lyse some epithelial cells in your respiratory tract, or you can damage the cilia of your respiratory tract that are meant to kind of bounce Staph aureus and Staph pneumoniae or Strep pneumoniae out so that they don't get into your lungs. But if you damage those cells, then Strep pneumo goes into the lung, Staph aureus goes into the lung, and now you have pneumonia. So it's really associated with some sort of predisposing condition, specifically viral infection is the most common. Staph aureus is also the most common cause of septic arthritis in adults, as well as osteomyelitis. And then the other thing that it's been known to cause on occasion is endocarditis. And in this case, we're not talking about subacute endocarditis. We're talking about acute bacterial endocarditis. This is especially true in patients who have damaged heart valves for a variety of reasons. It doesn't really matter why. What matters is that the valves are not working right. And what that tells you is that it can also be a problem for patients who have prostheses of any kind. So part of the reason it causes bacterial endocarditis is because of these damaged heart valves. And if you instead have prosthetic heart valve or any other kind of prosthetic, including like artificial joints, particularly the hip, you can get localized pain and mechanical failure of that joint or prosthetic. Treatment basically consists of removing the prosthetic and then putting the patient on antimicrobial therapy. Okay, so I've talked about a lot of kind of scary diseases that can occur as a result of Staph aureus. So how do you treat it? Well, first off, you need to be aware of MRSA. So anytime you're dealing with Staph aureus, you need to check its antibiotic resistance to methicillin. If it's methicillin sensitive, you should try nafcillin. That's kind of a recommendation that is often given, NAF for staph. It's how some people choose to remember it. If it's methicillin resistant, try vancomycin. And that's all I have on Staph aureus.